an overview of advanced prostate cancer and the various treatment options, to share patient care management strategies, and then I'll close by discussing the role of the nurse practitioner at the London Regional Cancer Program and a bit more about the clinics that I lead. So the discussion points. So this presentation has originally been crafted for a review of prostate cancer for nurses. So I discuss prostate cancer, Gleason scores, and grade groups, the prostate cancers that we see in medical oncology, some definitions regarding high volume, high risk, the natural history of the disease, markers, and then we'll delve into the treatments and the NP-led clinics. So first, what is prostate cancer? 95% of prostate cancer is adenocarcinoma, meaning it starts in the prostate gland. The most common cancer in Canadian men, about 1 in 8, and about 1 in 29 will die from the disease. Risk factors are various, but include age greater than 65, an African ancestry, first-degree family history, germline mutations, especially BRCA2 and HOXB13, obesity, a tall height, high consumptions of dairy, chemical exposure, prostatitis, smoking, and high androgen levels. But BPH is not considered a risk factor. The diagnosis is primarily made by the digital rectal exam, PSA, blood tests, and then, of course, a biopsy. The most common sites of metastases are in bone, about 80%, with distant lymph nodes and liver, about 10%, as well as the chest, about 10%. Brain metastases are rare and occur in less than 1% of patients. So the Gleason scores and grade groups are key criteria that we used when we're assessing these patients and making diagnoses. So grade groups, grade describes what the cancer cells look like under the microscope. The Gleason grade is the most predominant pattern, and the second most predominant pattern of the biopsy added together to generate the Gleason score. Gleason score of 6 is considered low grade, 7 intermediate, and 8 to 10 high. Over in 2014, the International Society of Urologic Pathology released a revised grading system titled Grade Groups, which is a simplified grading of 1 through 5. And you can see that the higher grade groups, grade 4 and 5, have those higher Gleason scores of 8, 9 to 10. And it's also important to remember the intermediate group of 4 plus 3 totaling 7, rather than the lower risk 3 plus 4 totaling 7. And on the right, you can see the Gleason pattern, which demonstrates the decrease and more poorly differentiation the higher the Gleason score is. So the main types of prostate cancer that I see and deal with my med-onc colleagues, metastatic hormone-sensitive prostate cancer, or also known as MHSPC. An additional term now that's being used is castration-sensitive prostate cancer, or MSPC. So in general, this means that the PSA drops in the presence of antideprivation therapy. Conversely, metastatic castration-resistant prostate cancer, or mCRPC, is a PSA rising in the presence of ADT. The third being non-metastatic castrate-resistant prostate cancer, or M0 as we call them. So we see a PSA rising in the presence of ADT. However, there's no metastases on conventional imaging, which is CT and bone scan. And then there is another group called small cell carcinomas of the prostate, which are rare and aggressive variants and usually are non-PSA producing. Definitions of high volume and high risk. So high volume has criteria from the charted trial. Visceral metastases, or 4 or more bone lesions with at least 1 beyond the vertebral bodies and pelvis, whereas high risk criteria from the Latitude trial, at least 2 of the 3 factors. So a Gleason of 8 or more, at least 3 bone lesions, and visceral metastases present. So the natural history of prostate cancer can be seen in this diagram here. So most men start with some degree of localized prostate cancer, but there are men that do show up with de novo metastases, which would be considered metastatic hormone-sensitive patients. However, if they are localized, they can develop what we call non-metastatic hormone-sensitive prostate cancer, which can convert into non-metastatic CRPC or converting into metastatic CRPC. So I'll talk about the markers in some greater detail, because these are definitely top questions from patients and staff. So what is up with PSA? So PSA is a protein that's made by healthy and malignant prostate cells, primarily in the semen, and helps sperm to form freely in the ejaculate. Small amount of blood, which can be measured to inform prostate cancer activity, and PSA half-life is about 2 to 3 days. The primary tumor marker for patients with metastatic prostate cancer. In the metastatic setting, the trend and kinetics is the primary focus that we look at. And a PSA of concern, we follow a general rule of a PSA doubling time of 3 months or less. So initially when these patients are seen, especially on ARATs, we would check the PSA every 3 to 4 weeks, and then every 3 months once they're established on treatment. And I always keep a note about the importance of OHIP eligibility criteria, especially on outpatient recs, that we must include the fact that it is funded because they have a diagnosis. Alkaline phosphatase, or ALK-Phos, is another marker we pay close attention to. This is an enzyme found in the body which is responsible for catalyzing organic reactions. About 80% comes from the liver and bone. It's a good indicator of bone turnover and acts as a secondary tumor marker alongside PSA. Rising alkaline phosphatase, especially when the liver function tests are normal in patients with prostate cancer, is indicative of progressive bony metastases, versus a decreasing ALK-Phos indicates treatment response in the bone. It's checked every 3 to 4 weeks when starting systemic therapy, and then the same as PSA about every 3 months thereafter. And the curves I put on the right just demonstrate how, typically we would see alkaline phosphatase and PSA follow a downward trend together, which is key with reviewing the labs. Testosterone is also important. So it's an androgen, or the male sex hormone, responsible for development of the male sexual organs, including the prostate. It definitely fuels prostate cancer cell growth. Luteinizing hormone releasing hormone, or LHRH, or conversely also known as GnRH, is released from the brain to the testes to initiate testosterone production. The testicles are the main source of testosterone, producing about 95%, where the adrenal glands produce a secondary source, the remaining 5%. Measured on routine labs and important include for all monitoring and to assess for purposes of treatment funding applications as well. So I'll talk about androgen deprivation therapy a bit. It's definitely the cornerstone of metastatic prostate cancer treatment. So the goal is to suppress testosterone production, to starve the cancer of fuel, and therefore control the disease. It's a lifelong treatment when metastatic disease is present, primarily achieved by using LHRH agonist or antagonist injections. Bilateral orchiectomy is also an option. Common adverse effects or side effects include fatigue, hot flashes, weight gain, gynecomastia, decreased muscle tone, decreased body hair, decreased bone density, dry skin, and anemia. And I've provided a table of the two classes, so the agonist on the left, and you can see the antagonist on the right. And I'll talk a bit more about the differences here. So in terms of the agonist group, the most common would be leuprolide, which includes Eligard and Lupron, as well as goserelin or Zoladex. Its main mechanism interferes with normal release of LH in the pituitary, therefore almost overstimulating the cycle and downregulating release. Testosterone increases in the first 1 to 3 weeks before dropping, which may cause a flare. And this is mitigated by bicalutamide pre and post to help settle down those hot flashes and any potential pain. The pros is that it decreases the frequency of administration and is usually well tolerated, and the patients can be transitioned from an LHRH antagonist to an agonist over time. The cons is the initial flare, which may not be tolerated or too risky, especially in those de novo metastatic patients. On the antagonist side, we see Degarelix or Firmagon, which is provided in a loading dose of 240 milligrams once, and then 80 milligrams subcutaneous over 28 days. It uses a mechanism to block LH release from the pituitary directly, and the testosterone decrease usually occurs within 24 hours. The pros is that you can obtain an almost immediate release of testosterone, especially for those patients with de novo metastatic disease, where we'd be concerned about pain or significant morbidity. It works if the LH agonist also fails to suppress testosterone, and sometimes patients do need transitioning back to the antagonist therapy. The cons is the frequency of injection, skin irritation at the injection site. So I'll talk at length now about the access target anti-androgen therapies, or ARATs. Androgen receptors are located on prostate cancer cells. Androgens, so testosterone and dihydrotestosterone, bind with these androgen receptors to mediate tumor growth via regulating gene expression. ARATs are a class of oral medication that either inhibit androgen synthesis or they block androgen from binding to the receptors using different mechanisms. So you can see the two classes there. Abiraterone is in a class of its own, also known as Zytiga, which is an androgen biosynthesis inhibitor, and then enzalutamide, which is Xtandi, apalutamide, which is Erleta, and darolutamide, which is Nubeqa, are androgen receptor inhibitors. So ARAT use, when and where. So you can see that ADT is used a lifelong for these men as they move through the different metastatic categories. So these tables provide just a snapshot of what we're doing in Ontario and where the funding is also placed. So abiraterone can be used in hormone sensitive, but is not EAP funded, whereas apalutamide and enzalutamide are. And then we can also use darolutamide plus docetaxel plus ADT, or abiraterone plus docetaxel plus ADT as what we call a triple therapy. And I'll talk a little bit more about that. In the metastatic castrate-resistant setting, we have abiraterone and enzalutamide, and then in the M0, we have enzalutamide, apalutamide, and darolutamide. So in terms of abiraterone, Zytiga, the standard dose is 1,000 milligrams daily, and it's also taken along with prednisone 5 milligrams twice daily. Key thing about prednisone is it must be taken concurrently to reduce side effects from mineralocorticoid excess, which can cause hypertension and fluid retention. Rotation 2 dexamethasone, 0.5 milligrams daily, can be made if the patient's PSA starts to rise. It's a simple rotation that we can make from prednisone to dex to try and achieve PSA control. Abiraterone must be taken on an empty stomach, but prednisone is best with food. Abiraterone is also available in 500 milligrams and 250 milligram tablets, and it is the only one of these ARAT therapies that has gone generic to my knowledge. We consider dose reductions if tolerance or adverse effects are a concern. It is avoided typically for patients with a significant cardiac history or diabetes. And then the adverse effects I've listed are provided in the CCO teaching sheets that we review with our patients. So I've underlined the key ones that we really focus and emphasize on with each one of these therapies. So definitely liver problems and hypokalemia are the two leaders with abiraterone, but patients, almost universally have some level of fatigue, joint muscle pain, edema, hot flashes, constipation, diarrhea, hypertension, hyperglycemia, and nausea with the ARAT-based therapies. And as mentioned, EAP is available for only castrate-resistant disease, but not for hormone sensitive. Abiraterone also has a newer indication, which we started using it under last year. So it's for the high-risk non-metastatic prostate cancer patients. So high-risk node negative, as per the meta-analysis in the 2 STAMPEDE platform phase 3 trial by Attard in 2021 in the Lancet. So is defined as having at least 2 of the following, so tumor stage T3 or 4, Gleason score, a sum of 8 to 10, and a PSA concentration over 40, or the patient can be relapsing with high-risk features. It's also included in the study were non-metastatic node-positive patients. The therapy continues for 2 years or until progression, whichever comes first. And 6-year metastases survival of 82% was demonstrated in the combination group compared to 69% in the control group, which was ADT alone. This is not EAP funded yet. However, it is available through a patient support program. So enzalutamide or Xtandi, the standard dose is 160 milligrams daily. It comes only in 40 milligram capsules. It can be taken with or without food, and the patients are reminded not to open the capsules. They are rather large. Take all 4 capsules at once, and typically it's recommended at bedtime. This is just anecdotal from patients, but they find that that seems to be the best time as it makes patients tired in the hours after ingestion, so they just rather be asleep. We do consider dose reductions for tolerance or adverse effect concerns, and key things that usually is avoided with patients with a seizure history, and it should be used with caution with patients that do have pre-existing memory impairment. The key adverse effects are similar to abiraterone, but a few highlighted ones: low appetite, weight loss, and confusion. And it is funded EAP for both hormone sensitive, castrate resistant, and also for the M0 group. Apalutamide or Airlida comes in a standard dose of 240 milligrams daily, 60 milligram tablets, so totaling 4 per day. With or without food, again, it's the same recommendations all at once at bedtime. Dose reductions do occur and usually avoided with seizures as well, and also particular caution with patients that are at risk for falls. That was a demonstrated concern in the study. Some unique things about it is rash. I have definitely seen the rash. There can be treatment with steroid topical preparations, but some patients we have had to stop and rotate to an alternate ARAT. And then, of course, the falls and fracture risk is reiterated. And the funding is available through EAP for hormone sensitive and M0. So darolutamide or Nubeqa, it is 600 milligrams POBID, so that is unique. Most are daily, but this one is twice daily. It comes in a 300 milligram tablet taken with food, and it's to be taken with 2 tablets twice daily. Recommendation for reduction is there. Um, Unique things, it does have minimal penetration of the blood-brain barrier, so this should decrease CNS adverse effects. It can cause liver problems and fatigue. Funding is available for M0, but also it can be accessed through a patient support program in the hormone-sensitive setting for patients that would be candidates for triple therapy. So again, darolutamide, docetaxel, ADT. I'll talk about chemotherapies. So we do use docetaxel or Taxotere. This is a taxane-based chemo. It's given IV every 21 days. In the hormone-sensitive phase, 6 cycles plus or minus darolutamide or abiraterone in the triple therapy setting for high-volume disease, or for metastatic castrate-resistant, 10 cycles plus prednisone. It's one of the most well-established treatments of metastatic prostate cancer. Adverse effects are typical to chemo, but hair loss, low platelets, fever, fatigue, neuropathy, rash, edema, mouth sores, diarrhea, nausea, nail changes, allergic reactions, and joint muscle aches. And it's fully CCO funded for these men. Cabazitaxel or Jevtana is an additional taxane chemo, which is also every 21 days. Typically, where we look to considering rotation from docetaxel to cabazitaxel is if they're progressing on or after docetaxel, after ARAT for MCRPC, or if they're progressing on or after ARAT after docetaxel. So you can flip the two. 10 cycles plus prednisone twice daily. Side effect profile is quite similar. Other options, so mitoxantrone is a well-established chemo. If tonsil docetaxel is an issue, we have used this in the past. Also ECF, which is a combination of epirubicin, cisplatin, fluorosil, can be considered for those with liver metastases. Carboplatin is a salvage chemotherapy post-docetaxel progression. We have used oral cyclophosphamide as well for frail patients that are not suitable for IV chemo. And then prednisone on its own, 5 milligrams twice daily, is a great palliative option. It does have an anti-androgen effect to some degree, and it may help with energy, appetite, and pain management. Radiopharmaceuticals, so Xofigo. So this is a radioactive isotope that's given intravenously every 4 weeks for a total of 6 cycles. It's an alpha particle that binds to prostate cells in the bone and delivers radiation this way. It's indicated for patients with bone-only progression after an ARAT. It's typically preferred at our center before docetaxel to avoid using this therapy in those that have pretreated marrow. ALK Phos is the main marker of response, while PSA will rise, which is definitely an important point to discuss with patients, as they may be surprised that their PSA is rising to some degree on this treatment. Adverse effects, pain flare, especially if they are already having painful bony metastases at the time of treatment initiation. Diarrhea, nausea, vomiting, edema, and low blood counts is the most significant side effect that is monitored for. At our center, it's given in our nuclear medicine clinic on a Wednesday afternoon. The patient must be assessed back at the cancer center 1 week before the treatment with blood work. I typically notify our nuclear medicine department by the Wednesday 1 week before the treatment to confirm so that the treatment has time to make it to Canada from the site of manufacture, which I believe is in the United States or in Sweden. I've heard of both. CCO funding is administered, correction is applied in this situation. Lutetium-177, also known as Pluvicto. This is a targeted radioligand that's given intravenously every 6 weeks for a total of 6 cycles. So the vipivatide component targets and binds to prostate cancer cells that express PSMA, which stands for the prostate-specific membrane antigen. Whereas the lutetium component is a radioactive isotope that delivers radiation to the tissues it's bound to, not just bone like in radium. It's indicated for patients with a PSMA positive that are PSMA positive post ARAT and docetaxel. PSMA avid disease must be proven on a PET PSMA scan. Adverse effects are included, which are similar to the previous. It is now Health Canada approved, but up to this point has only been available through clinical trials, and now, to my knowledge, a center in Montreal and British Columbia. Some of our patients have traveled to that want to access it privately. So radiopharmaceuticals, a little more on their mechanism of action and the difference between the two. So you can see that radium is only binding to the bone, where you can see that the lutetium piece is using both components of the vipivatide to bind and then deliver the lutetium component. And that would be not just bone, but any tissue that expresses PSMA. So now, genetic testing has definitely ramped up in the last 2 years, I'd say, at our center. So in terms of germline, so this is the inherited pathogenic variant that is present at birth, which can be passed on to children and also be present in the patient's siblings. So CCO, it does provide detailed guidelines for who qualifies for hereditary cancer testing in prostate. So they have to have either a personal history of metastatic disease, a documented personal history of high risk locally advanced prostate cancer, a personal history of prostate cancer in greater than one close relative, or a personal history of prostate cancer with greater than two close relatives with either prostate, pancreas, ovarian, and or breast cancer. At our center, we test for 19 genes. So I've highlighted the three with underlines of ATM, BRCA1, and BRCA2 are of particular interest. But you can see there's a number of other genes such as BARD1, CHEK2. Some of these genes are more leaning towards the breast profile, as it is a combination panel that can be used for breast patients as well. In general, about 18 to 16%, 8 to 16% of patients with metastatic prostate cancer do have a DNA damage repair mutation. This limits the cell's ability to repair and recover from other mutations that develop. In my practice, this is now being offered to every patient with metastatic hormone-sensitive prostate cancer, castrate-resistant prostate cancer, and then on a case-by-case basis, for those M0 men, we would have to follow up and make sure they meet other criteria that CCO's outlined. I explained that this is a simple blood test that can be completed on their way out from our clinic, and we've been getting results back within about a month to 6 weeks, I'd say. If the result is positive, I typically review this with them over the phone and review them for genetic counseling, and I would make a referral for that component. The patient may also be a candidate for olaparib if they demonstrate BRCA1, 2, or ATM positivity. On the flip side, we also do offer somatic testing. So these are considered acquired pathogenic variants of genes associated with prostate cancer for environmental exposure or lifestyle choices. The test by request for reflex tumor testing on previous biopsy specimen. So we're testing for ATM, BRCA1, BRCA2, and also PALB2. It's taking anywhere from 1 to 2 months to obtain result. There are some limits, specifically the age of the specimen. In discussions with the lab, tissue anywhere from 5 to 10 years older might be challenging to the point where they would not be able to run the test. And if we do require this, rebiopsy of new tissue testing would be required. Somatic mutations may change over time due to their instability of tumor genetics or pressure from treatment as well. And about 20 to 25% of men have somatic DNA damage repair mutations. The frequency does increase in metastatic versus localized disease versus 8 to 16% in the germline. A little more on BRCA1, 2, and ATM. So inherited BRCA2 mutation causes a 30% risk for developing prostate cancer. There is some variability in the trials based on certain risk modifiers. BRCA1 mutation is about a 13% risk, so it's pretty similar to that of the general population. Both are tumor suppressor genes involved with DNA repair. Defects resulting in genetic instability result in tumor development. BRCA2 mutations result in prostate cancer at a younger age with increased Gleason score, lymphadenopathy, distant metastases, and mortality risk. BRCA2 mutations increase risk of male breast cancer as well to 8% compared to 1% for BRCA1. ATM does not, ATM does increase the risk of prostate cancer, but the rate is unclear. Responsible for actions as it does act as a DNA checkpoint to support DNA repair mechanisms. I'll talk about the targeted therapies that are related to genetics now. So in terms of olaparib or Lynparza, so it comes in a standard dose of 300 milligrams twice daily, either a 150 milligram or 100 milligram tablet, with or without food to take it. We do consider dose reductions if tolerance is a concern, namely diarrhea, nausea, vomiting. It's a classification of a PARP inhibitor, which blocks DNA repair and replication cancer cells. It's indicated for patients with BRCA or ATM mutations with metastatic castrate-resistant prostate cancer who have progressed after an ARAT. Testing for mutations, either germline or somatic, must be complete in order to qualify. Adverse effects, anemia, low blood counts, fatigue, nausea, vomiting, diarrhea, and dyspnea, and there is EAP funding available. Olaparib is now being used also in combination with abiraterone. So the standard dose applies of the olaparib, plus the standard dose of abiraterone. Prednisone also must be taken in its standard dosing of 5 milligrams BID. This is indicated for patients with confirmed BRCA mutation with metastatic castrate-resistant prostate cancer, whom chemotherapy is not clinically indicated. So I'd like to just point out that ATM is not included in the indication for combination treatment. And most common adverse effects from the PROPEL trial demonstrate anemia, fatigue, and nausea. So similar to what I'd already stated. We also have a new PARP inhibitor called niraparib that's also available in combination with abiraterone. The combination itself is called Akiga. It comes in a standard dose of 200 milligrams of niraparib plus 1,000 milligrams abiraterone in a single combination pill. So one daily dose. It's taken without food. It's used with prednisone 10 milligrams daily, and special dose adjustments for anemia, thrombocytopenia, or neutropenia are identified in the product monogram. So for example, anemia, if it's greater than grade 3, you would hold the Akiga and switch the patient to single agent abiraterone plus prednisone and provide supportive care with weekly monitoring until they return to a less than grade 2. You would then restart the Akiga at a reduced dose. So that would be 2 tablets of 50 milligrams of niraparib plus 500 of abiraterone plus prednisone. And if this recurs, you would repeat. It's indicated for patients with confirmed BRCA mutation, again with metastatic castrate-resistant prostate cancer, who are symptomatic or mildly symptomatic, who chemotherapy is not clinically indicated for. Anemia is a leading adverse effect, as well as hypertension, constipation, fatigue, nausea, and thrombocytopenia. At present, to my knowledge, it is still only access to a patient support program. So putting all this together, I really like this diagram. It shows how the patient moves through the different classifications of metastatic disease. And you can see how the different ARATs and chemo are lumped together, especially in the beginning, versus as the patient moves through, we see docetaxel and radium showing up, as well as abiraterone and enzalutamide if these haven't been used up front. You can see lutetium is placed there alongside cabazitaxel later on. A few comments, you do see Siplusal T, which is a vaccine-based therapy that manipulates T cells. This is not approved by Health Canada, as well as pembrolizumab or rucaparib. So I will talk a little bit more about supportive care now for these patients. So especially for the bone metastases. So this is a big one that I deal with in my clinics. So the most common sites of metastases are in the bone, causing pain, increased risk of fracture, and negatively impacting quality of life. So we look to denosumab at 120 milligrams subcutaneous every 28 days. It's also known as brand name Xgeva, which is different than brand name Prolia. It's indicated and EAP funded for patients with bone metastases with metastatic castrate-resistant prostate cancer. So it slows impossible to reverse some of the bone loss associated with ADT and the ARAT-based therapies. It does have some adverse effects, the leaders being joint muscle pain, hypocalcemia, and also there is a risk of osteonecrosis of the jaw, which tends to increase after the 1-year mark. We can also use zoledronic acid with concurrent dose of Taxol. We can also use oral bisphosphonates if bone loss is demonstrated on bone mineral density testing, or denosumab 60 milligrams subcutaneous every 6 months, which is known as Prolia. This last statement about the oral therapies and Prolia is I tend to use this more for men with hormone-sensitive prostate cancer because the denosumab at 120 milligram strength is not funded for them. I'll talk very briefly on radiation in the metastatic setting. So there is definitely a role for radiation for oligometastatic lesions, typically fewer than 5 lesions, when patients do progress on their ARAT therapy. The most common application in our clinic would be when a patient is developing PSA progression. We would start to work them up with CT bone scan. This would demonstrate oligometastatic progression in the bone or the lymph nodes. Radiation is quite beneficial when patients do have these clinical signs of progression, such as bone pain from their underlying bone metastases. But we do continue with the ARATs and continue with PSMA and symptom review post-radiation to determine response. Typically 1 to 5 fractions depending on location and how RAD-onc feels it's appropriate to deliver. So now I'll talk about my NP-led prostate clinic. So I'm following about 120 men on ARAT-based therapies, typically seeing about 12 patients every Friday in our Bain Center, which is the name of a certain clinic space I use. Visits are considered a transfer of follow-up from the medical oncologist. Patients are typically assessed about every 3 months, and it's a combination of in-person versus telephone follow-ups depending on where the patient lives and how they're doing. Blood work is typically completed in the community, which was established because PSA does take about an hour and a half to actually obtain result back if it's drawn day of visit. And newly, we have had support from our registered nurses added into this clinic just in late 2023. So typically my visits review the tolerance and response to the ARAT, ADT, and offering the supportive treatments such as denosumab. I'll discuss their adverse effects, which are the side effects mentioned, so I won't review that again. But we look at their PSA trend, routine labs, which is not just PSA, but looking at their CBC, their lights, renal function, liver function, ALK phos, testosterone, and thyroid. We will administer the ADT injections and denosumab if the patient chooses to have them done in our clinic. Some do enjoy using the home programs that the companies provide and also home care or their family physician. I renew their prescriptions, which is primarily focused on prostate cancer treatments. And I will assess for signs and symptoms of progression, and I will organize the CT and bone scans in conjunction with their oncologist. And referral is common, especially to radiation oncology and urology, depending on concern. I will also usually complete the germline and somatic testing if it hasn't already been done, and make the referral to counseling if we have a positive result, and then ordering the bone mineral density testing and monitoring that moving forward. So in terms of symptom management, these are kind of the key areas of focus that I discuss. So the most common symptoms reported would be fatigue. ADT is the major driver, and it's compounded by further treatments such as the ARAT. We talk about, management such as swimming, walking can be helpful, combating muscle loss. And I do have some resources from Prostate Cancer Canada that really do provide a good review about fatigue management strategies that we can also give them. Talk about taking breaks and resting, to resume activity afterward, not overdoing it. But dose reductions are offered and reviewed, and sometimes we have to go to lengths of using some low-dose prednisone. Hot flashes are a very common concern, especially when ADT is started and definitely compounded by the ARAT addition. It's definitely worse in men that are younger than age 70 in my experience. It does tend to fade over months to years, but usually never totally goes away. We have resorted to treatments with oxybutynin, venlafaxine, and megestrol, but these do have their own risks, especially clot risks with some of them, and also adding further side effects. Pain, especially to the backs and hips, spinal cord compression is always on my radar in these men. The pain is primarily associated with bone metastases. We can use Tylenol and opioids or a combination of the two. Restaging scans to evaluate radiation consults, and also working closely for palliative care consultation to help manage these men forward. Anemia of chronic disease is definitely associated with their low testosterone. I have dealt also with compounding iron deficiency anemia, but this tends not to be the most common source. It's definitely a component of their chronic fatigue. And monitoring, as well as referral, I have had some men with developing pancytopenias where hematology has been consulted. So the last portion, I'll talk in general, more high level about what nurse practitioners are doing at the London Regional Cancer Program. So in terms of the history, when I joined the team in 2017, there were about 2.2 nurse practitioners working. So one was dedicated for our breast team, which was focusing on patients on systemic therapy, and also running a nurse practitioner-led lymphedema clinic at that time. The second nurse practitioner was splitting their caseload between the head and neck team and also GU. So on the head and neck side, they were supporting a symptom management clinic for patients on concurrent chemo, plus radiation therapy. So this clinic really focused on nutrition, hydration, and and pain management, which really did support measures to reduce the need for hospitalization admissions for these patients. On the GU side, the NP was running the testicular cancer surveillance program and also assessing patients in the med-onc clinics on systemic therapy, which included prostate, renal cell carcinoma, and bladder cancers. The remaining nurse practitioner that was working 1 day a week was hired to pilot an offsite clinic in approximately 2016. They were solely focusing on patients on ARAT therapies for castrate-resistant disease that were considered stable by their referring medical oncologist. The visits really focused on symptom assessment, PSA trend, renewing the ARAT prescriptions, and giving the ADT injections. So I was hired on to take on the GU caseload, and a second NP was hired to replace the NP retired from the breast team. So that left us with a total of 3 nurse practitioners by 2017, plus the NP working 1 day a week did continue for some time. So in terms of our model, there's now 12 of us working at the LRCP, and we do cover primarily patients on systemic therapy. Our role is really defined by the disease site, and we mostly work in the outpatient setting, seeing these patients. So there's 2 of us for GU now. There are 2 for the breast team, 1 remaining for the head and neck team, 1 for lung and esophageal. We also have a dedicated nurse practitioner for our stem cell transplant program on the outpatient side, with 2 NPs for our inpatient hematology unit, which do focus on the transplant aspect, but also other patients with hematologic malignancies. We also have 1 NP dedicated in our patient review area, which is basically assessing patients on radiation therapy. And this nurse practitioner also does play a key role with the movement of patients that are on brachytherapy. And now we've recently had 2 new positions created to pilot what we're going to trial as a systemic therapy assessment clinic. So the nurse practitioners primarily split their clinic time between supporting their respective medical oncologists and their disease site team, and also running their own NP-led clinics. So NPs also do cover the med-onc clinics independently in the absence of the physician for holiday vacation time. And we do sometimes cross over on disease sites, but this is typically not preferred. In terms of the NP-led clinics, so there's been a significant increase in the number of NP-led clinics in 2023 due to the cancer center acquiring more clinic space in the adjoining hospital. So now NPs do have 1 to 2 dedicated NP-led clinic days. So the NP-led clinics that I'm aware of compiling this list, so the NP-led prostate clinic is now running 2 days a week, so on Monday and Friday, and each day has a different nurse practitioner. So I would run the Friday and my colleague would run the Monday. So there's 2 separate rosters of patients. The testicular cancer surveillance clinic runs on our Thursday afternoons, and the 2 GU nurse practitioners do work together. The head and neck symptom management clinic is Tuesday, Friday. We have a lung clinic on Fridays, as well as NP-led breast clinic on Fridays with 2 nurse practitioners. In the patient review area, it's a mixed model with the NP and GPO working together on most days of the week. And then the stat clinic will have 2 NPs working together for 5 days a week. We do have nursing support. As I said, this is a new addition on most clinic days, but it is dependent on staffing. There's also in the Test surveillance program what we consider advanced RN support. So this means that our registered nurse is actually conducting independent follow-ups on patients that have been deemed appropriate by the nurse practitioner. Results are reviewed and communicated if they are normal to ensure that the registered nurse is working within their scope of practice. If a patient is not doing well and this is discovered by the RN, then the NP will review. The RN also does document, and the NP would enter all the orders for the testing and follow-up required for those visits. We have clerical support, which is also assigned to our NP-led clinics. We've had amazing buy-in and support from the oncologist, which has really been pivotal moving this forward in time. And the patients are typically being referred by the oncologist, but the NP can also self-refer if they feel that a patient that they're seeing in the oncologist clinic would be appropriate to move to the NP-led clinic model. Some NPs do have an established referral form, while others do not. It really depends on the team, and I find the size of the team, especially the breast program, there are many oncologists treating breast patients. So a form has been more successful with that group. And we do see patients that are progressing that do require assessment by the oncologist, and we simply have a mechanism to book them back to the oncologist's clinic. It is not considered a new referral by any means. So my final thoughts, the number of nurse practitioners have increased over the years because the need for patient care in oncology has also increased in terms of the volume of patients and the treatments that can be offered. NPs at our center meet this need by supporting med-onc practice directly, by seeing patients in the physician's clinic, and also transferring patients to the NP-led clinics. Support and collaboration to develop and maintain these roles and clinics has also been significant among the physicians, the NPs, and also management. So with that, I'm ready to take any questions that anyone might have.
Great, thank you. Thanks, Matt, for this great overview of prostate cancer, but also, you know, what, you know, I guess the role of nurse practitioners at your center. So if anybody has any questions, please feel free to ask them in the chat or otherwise unmute. Happy to entertain those. Maybe while we wait for questions to come in. Matt, I guess I had a quick question. So, you know, you said you have nurse practitioner-led clinics, and then you also, I think, work in some of the clinics. I'm just curious, what patients would be assigned to your, you know, nurse practitioner-led clinic versus would stay with the oncologist? Do you have guidelines, or like how does that work?
Yeah, I wouldn't say we have anything written in terms of guideline, but in terms of the prostate clinics, so it's definitely limited to patients on ARATs. I have not been following patients on radium or chemo in those clinics because it's just not conducive to the model. It's not conducive to the you know, the limitations on labs with systemic therapy. All that has to be built in. So there's more freedom in terms of the bookings when it's just oral therapy. So that's been one part of it. In terms of selecting the patients, I know there are some strict criteria in the breast program. It depends on what the treatment is, where they're at with the treatment. So that does vary a bit across the NP-led clinics for sure.
Urban Ameneger is asking, first of all, great presentation. He's asking, so the numbers of nurse practitioners went up over the years. Can you comment what happened to the numbers of RNs at the same time at your cancer center?
Yeah, so the RN numbers, to my knowledge, hasn't changed in any negative way. In fact, if anything, it's increased because the center has provided further support with an RN in the nurse practitioner-led clinics now, which has been amazing. I have always had that in the testis surveillance clinic, and I made the comment about the advanced role. We felt because the clinic is very based on algorithms in terms of surveillance schedules, that at certain points, if the patients are doing well, then that could be something that the nurse could follow up independently. So we introduced that about 6 years ago. So I do have hopes and plans to use something similar in the prostate clinic for those men that demonstrate PSA stability, perhaps like phone follow-ups in between visits with me. And we can always coordinate, you know, a visit with me if the need should arise. So those are all very positive things that NPs and nurses have worked together on moving forward.
And I'm just kind of curious about, you know, how the relationship works with these patients. So I mean, you know, it sounds like you start following them when they're in the HSPC setting, or probably get to know them over a few years. Obviously, eventually they progress, and often they'll probably be switched to chemo or something. Do you find that you then end up following them when they're back in the med-oncs clinic? Like, how does that relationship evolve over time?
That's a good question. I'd say now that there's two of us, so we've actually set it up quite well that I work with two oncologists, and my colleague that's also doing this clinic works with the additional two med-oncs that do prostate. So we tend to be now referring patients from these physicians that we work with. So it's basically the three of us now seeing these patients. So if the patient does progress and goes back to the med-onc, then I will see them in their clinic moving forward. So it has been nice in terms of patient flow and continuity of care for sure.
And so there's another question here. What is your model of collaboration with pharmacy and drug navigators? Are you submitting EAP requests? How does that work?
Yeah, I am not submitting the EAP request myself. I do have a very good relationship with our two drug access facilitators. I find, especially with the supportive therapies like denosumab, I'm usually the one initiating those. So there will be a lot of correspondence to renew, send copies of the EAP to the patient's home pharmacy. In terms of our pharmacists, we do have a dedicated GU pharmacist. So I find that we do correspond via email, especially for patients on radium or funding nuances. So I'd say there is fairly good collaboration with the pharmacy side of this.
We have another question here from Meredith Marson. So the NP is working with within the systemic therapy assessment clinic. Do they follow a specific population or a site group, or how does that work?
Yeah, this is developing for sure. We have tried to keep the criteria about which patients that would be seen there for symptom assessment quite narrow in terms of, trying not to, put patients in the clinic that should have just gone to emerge anyway. I think the goal is really to try and deal with the symptom and with success so that we don't have to send the patient to emerge. But it is coming from all disease sites at this point in time, to my knowledge.
Great. I waiting for some of the additional questions to come in. So I guess you mentioned you added I guess a nursing support to your clinics, right, recently. I guess can you just maybe speak to that? Who does what in the clinic? What are the responsibilities? What was the I guess the impetus for adding the nurses?
Yeah, sure. So in my clinic, the nurse and I have like a specific template that we use to prep, which basically complement each other. So the questions regarding symptoms, assessing vitals, reviewing their medication, the nurse would provide me with all that information. And then my assessment would complement those points that have been raised of concern or that need further review so that we're not basically repeating everything that each person has done. And with the goal is to increase volume and flow through the clinic.
Interesting. And I guess did you develop this sort of model on your own, or did you follow some template that was being done elsewhere in Ontario or in Canada? Do you know how this sort of grew?
I had great mentors. I'd say the testis surveillance clinic is the oldest clinic that has been established. That has been run probably for about a decade. And originally the clinic had a mix of patients in the med-onc clinic, and the NP that was working there would try to see them. But they realized that if you can pull all these patients to a single day with a single provider, because it's so algorithm based with the follow-ups, that would be more successful. So that has kind of been the foundation of these NP-led model clinics, but picking the right patient focused clinics to really try and move them forward. And that way we're freeing up spots in the oncologist clinic for more complex cases and consults.
Yeah. Okay. Well, if there are no further questions from you, I'm going to solicit one last round of questions, if there are any. Seeing none, then I think we've asked enough questions already. Thank you so much, Matthew, for taking the time to to present the work you do. It looks great, and really happy that you were able to present this to us today. I'd like to also thank Bayer for helping facilitate this, and that's it. Thank you so much.